Dr. Biswas needs no introduction. He is the head of Uveitis and Ocular Pathology at Shankar Nethralaya, Chennai. And he's a teacher for majority of the uvea specialists of our country. He would be speaking to us on the role of injections and implants in uveitis.
I may exceed a little bit.
Sure, sir. You're most welcome to do that.
It's a very important topic, and all the topics were very relevant and important. And I thought that I'll share the injections in uveitis, which has become an important addition in the treatment of uveitis, both infectious and non-infectious. So the route of administration of drugs is the topical, systemic, and then come the periocular, and then intravitreal or intraocular injections. So regional drug delivery indications is that when topical therapy is insufficient, we know that intermediate and posterior uveitis, and then there requires intraocular high concentration of the drug at the site of the disease activity. For example, toxoplasma infection. Avoid systemic effects, the patient is high diabetic, we need to put the patients on intraocular intravitreal injections in such cases. In uveitic macular edema, topical non-steroidal or steroidal drops has got limited value, where intraocular steroid like implant or injections works wonder. Depot of corticosteroids, if non-compliant of oral steroids in our country, in our setup, it's often required. And then if there is a bilateral disease, and then you are treating with that drug, systemic drug, but one is very extensive inflammation, severe inflammation, otherwise a mild inflammation, you wanted to add injectable preparation in one eye in some situations. So how the local injection consideration? First is that where you want to give, periocular or intraocular. How long you want to the actions to there, months or years. Like fluoroacetate implant can work for 3 years, or where you clindamycin will work for about a week time, intravitreal clindamycin injection. You need to repeat after that one. Dexamethasone will work for 3 months. So the injection can be subconjunctival, subtenon, orbital floor, which the small limited group of people does that, and nowadays is not that popular. Intravitreal injections and implants has come in a very big way in the treatment of uveitis. So coming to the posterior subtenon injection, many of us are giving it, and the triamcinolone is the drug of choice. It's a readily available, cost-effective. You take 2 cc syringe, 27 gauge needle, 0.5 ml you give. Duration of action is 2 to 3 months. Complications, ocular hypertension and cataract, and some patients you can have levator palpebrace if you inject it, then there can be ptosis, which can be embarrassing to you. This is the posterior subtenon injection. This is a diagrammatic picture. You go vertically and then side-to-side movement, and then give the injection in the upper temporal quadrant. It should be given as posteriorly as possible so that you don't see it from anteriorly the injection side. If you don't give anteriorly, the chance of glaucoma is more. And this is a small video. I thought that the general ophthalmologist should be there. What I do cotton tube applicator. I put on the upper temporal quadrant, and I count 100 and make the people very comfortable, and none of my patients complain that there is a pain. They say that we didn't realize what time you have given the injection. And this is the way you give vertically and then side-to-side movement, you go posteriorly and push it. These are simple injections, and once you give it and see that somebody giving it, you can see that I stopped at 0.5 ml. And then intravitreal injections has come into that long way, and there are several intravitreal injections is given. It delivers the drug in therapeutic levels at the intended site. Refractory inflammation like cystoid macular edema, where intravitreal triamcinolone or intravitreal implant or biodegradable implant, dexamethasone you can give. So triamcinolone, coming to that one intravitreal injection, 4 milligram in 0.1 ml, usually administered inferotemporally, duration of action 4 to 6 weeks, may clear more rapidly out of vitrectomized eye than in an eye with intact vitreous. So intravitreal triamcinolone acetonide is compared with the posterior subteral injection. So there is a cataract progression in similar in both eyes, but what is very important is the IOP. IOP is more common rise in the intravitreal triamcinolone acetonide. It's notorious to cause rise of intraocular pressure rise, and you should be very careful. In a glaucomatous eye, you should not give the intravitreal triamcinolone acetonide. I won't give it. Intravitreal clindamycin is a very good treatment option, though we give systemic treatment in many of the patients, but in pregnancy, better safety profile, greater drug ability, macular lesion, macular threatening lesion, optic disc involvement, there is intravitreal clindamycin once a week, 1 milligram, 0.5 ml or 0.1 ml at weekly intervals is very useful. One, give with 400 microgram of dexamethasone, you may or may not give. I usually give it. And nowadays there is a work is going on to get slow release implant of clindamycin. Intravitreal ganciclovir is a great weapon. In case of CMB retinitis, is the best modality of treatment, and this will be followed by the oral valganciclovir. In acute retinal necrosis, apart from the, along with the intravenous acyclovir injection or intravenous ganciclovir injections, you should give intravitreal ganciclovir because it reaches very high concentration and save the retina. Systemically, therapy contraindicated as in renal insufficiency, 2000 microgram in 0.1 ml. We have given 4000 microgram in 0.1 ml in some cases of AIDS with CMB retinitis. Intravitreal moxifloxacin, pioneering work has been done by Dr. Manisha, and particularly in case of tubercular choroidal granuloma and subretinal abscess and frequent injections. She has compared with the anti-VEGF level and the response to the treatment. Non-resolving tubercular granuloma with persisting SRF, as I mentioned, 500 microgram in 0.1 ml injection. We have got one experience of publishing case of a single case report, intravitreal antivascular endothelial growth factor and moxifloxacin for the treatment of tubercular choroidal granuloma and subretinal abscess. Next comes the intravitreal implant, Retisart, Ojudex, Illuvian, Utic, and Excipia, of which the Ojudex is the cheapest. Other things are very costly. Retisart, we are not using it. A suture surgical implant, you have to do a surgery and put the fluorescein implant is there. Glenn Jaffe proposed it. It used since 2005. Releases 0.6 microgram initially and release vitreous over first month to increase 0.3 to 0.4 microgram day over 3 months. The drug, 30 months it works, but the drug is not available over here, and it has very notorious complication. Is 100% cataract in patients and 40% glaucoma, and this glaucoma is intractable. Most of them require surgery. I asked Glenn Jaffe, he said that he doesn't give that much of glaucoma, but my patients, a lot of patients got a significant loss of vision due to the glaucoma. Fluorescein acetonide uveitis study have given that intravitreal fluorescein acetonide implant 0.5 milligram, and it's decreased the risk of reference less adverse events than the Retisart. So we had participated in trial. Manisha, myself, is a co-author for this study. 0.2 microgram per day fluorescein acetonide intravitreal implant in chronic non-infectious posterior uveitis. This was published in Ophthalmology Science 2023. It reduced the uveitis recurrence, increased time to the first recurrence. You know, the uveitic is basically a recurrent disease, but the time gap is increased significantly. Control over macular edema, maintain stable IOP level, expected safety profile, high rate of cataract formation is the only significant complication. Huron trial is the significant milestone in the usage of uveitis treatment, intraocular injections, and this was done by Karen Loader when he used the two doses, 0.7 microgram dexamethasone and 0.35, 0.7 milligram, that is a 700 microgram, was very effective. It's a biodegradable implant. You inject in the vitreous cavity and it produces, it's almost like 90 to 90% success rate. IOP increased by less than 10% of the cases. And this IOP, even if it is increased, it can be controlled with the drugs only. This is a biodegradable implant, as I told, approved for non-infectious uveitis. Bevel entry into the sclera with a 25-gauge injector system. IOP as may be seen around 4 to 6 weeks after. And this is the Novadur system containing a polyglycan is used, slowly degrades into lactic acid and glycolic acid and disappears. This is a small video, and though the vitreoretinal surgeon nowadays there is a pack, paper pack is removed, and that intravitreal injector system is taken up, and this has got a tab. Tab is broken, and just pull up the tab, and then you hold it like a pen. Sleeve you remove it, hold like a pen, and then press over that one. Be careful that you don't put it in the anterior chamber. The slope pellet in that directed towards the optic nerve, and you give into the vitreous cavity. Don't give an aphakic eye, because it can come forward and the anterior chamber migration can occur. There is no need to do a suture. Yeah, this finishes the injection. And this is the biodegradable implant floating in the eye. It is rice grain size. We used 15 patients, and the Uveitis implant, non-infectious recalcitrant intermediate uveitis, and we found that the cystoid macular edema rapidly resolves with the sometimes rise of the intraocular pressure a little bit, which can be controlled with the medical treatment. And this is the implant in the vitreous cavity, and is getting slowly degraded. The POINT trial compared the intravitreal triamcinolone Ozurdex and subtenon TA and triamcinolone acetonide. Both the intravitreal injection is greater and faster therapeutic effect compared with the posterior subtenon injection, with modest increase in IOP, no significant difference between the two intravitreal injections. This is the POINT trial, which was published in Ophthalmology 2018. Intravitreal fluorescein acetonide Iluvien is used as intravitreal 0.9 milligram, 19 milligram of fluorescein acetonide, can be saved in selected glaucoma patients. Another implant which has been used in the UK Moorfields group, intravitreal 0.19 milligram of fluorescein acetonide implant, and this is the UTIC 0.18 milligram of fluorescein acetonide implant, FDA approved in 2018. And then suprachoroidal injection XC pair, I don't use it. This trial was happened in India also, and used as SCS micro injector. Dose is 4 milligram, 0.1 ml of 0.40 milligram MA suspension. Peachtree trial has evaluated the efficacy of safety of suprachoroidal CLSTA for macular edema secondary to non-infectious uveitis. Majority of the patient didn't require rescue therapy, and 50% cases reduction of cystoid macular edema can occur. MERIT trial is one of the very important trials. One should be remembering it, and it gives the green signal to the dexamethasone intravitreal implant, and it oversees methotrexate and ranibizumab. They compared it, and they found that dexamethasone scores quite high in the controlling of the cystoid macular edema. Multicentric uveitis steroid treatment trial found that the 7-year systemic corticosteroid immunosuppressive agents is better than fluorescein acetonide implant, though there is a follow-up loss of 30% cases. And I don't go into these details. SAFE study, sirolimus, which is not that very popular now, local formulation of sirolimus in non-infectious intermediate posterior and pan uveitis, and better tolerability, safety profiles, and the systemic steroid. It doesn't produce glaucoma. Sakura study is the efficacy and safety of intravitreal sirolimus in non-infectious uveitis in posterior segment. Kwandong is the main author of this paper. In conclusion, intravitreal therapy more effective and improving best-corrected visual acuity and CME, but the risk is associated with the cataract, particularly young people, and glaucoma, which in the dexamethasone implant or Ozurdex can be controlled with medication. but fluorosilane, particularly reticide, requires surgery. Newer delivery system being added to the armamentarium of corticosteroid injection. We still need to go some, before we tell that these are the well-accepted treatment, because well-designed control studies with long-term follow-up is required to find out the efficacy and safety of the regional corticosteroids. I'd like to thank Monisha to give me the opportunity, and I worked for this paper, and the studies I've gone through it, and I could share my knowledge. Thank you. This work is dedicated, my all academic effort is dedicated to life and legacy of Dr. S.S. Badrinath, my mentor.
Thank you, JB sir. I think nobody could have done a better justice to that topic, enumerating all the studies and all what is available in today's time, in the form of any intravitreal injection or implants. I just had one question, sir, that since we have so many implants and intravitreal dexamethasone implant is also there, do you still prefer to give a posterior subtenon tricot in any of your patients?
So posterior subtenon produces 18% glaucoma. 18% case of the glaucoma. I go into the economics of the patient. My first choice is Ozurdex, but most of the times in our country setup is not possible. I go to the posterior subtenon injection. It used to work, but we have found that many of the patients, even more than 18% in my imagination, is producing glaucoma.
Right.
So glaucoma is the main problem. If I've got a choice between the two, I'll go for Ozurdex implant. Ozurdex implant is a sure shot.
Right. Any questions?